Welcome to the Diversity Connector podcast, where we explore the rich tapestry of human experiences. I'm your host, Gertrude Mache, and I would like to acknowledge the traditional custodians of the country on which we meet today. I would also like to pay my respects to elders, past, present, and emerging, and together as we dive into conversations that bridge cultures, challenge stereotypes, and celebrate the unique perspectives each of us brings to the table. Each episode is a journey through stories and insights from a kaleidoscope of voices, each sharing their colorful narrative. Whether you're at home, on the go, or just anywhere in between, you're now part of a community that values understanding, inclusivity, and the beauty of diversity. So plug in your headphones, get comfortable, and let's connect through the power of our shared stories. Welcome, and thank you for joining us on the Diversity Connector podcast. Welcome back, everybody. This is Gertrude Mache here in beautiful Melbourne, Australia. And today I am graced with the presence of yet another fascinating guest. Welcome, welcome, welcome to our tribe. Please tell everybody your full name, where you're based, and share your story with us today.
Thanks, Gertrude. My name is Chris Pymble. I am the founder of Graphics et al. And I am based up in Brisbane, which is interesting because it's incredibly hot today. But I have a background in product development and graphic art, and I have found a way to weaponize that towards patient education. And that was not by any means a straight journey. I started out working as a product developer for very large government tenders, where the main part of my job was taking 20 or 30 page really complicated written information and translating it into a format that any manufacturer in the world would be able to understand. And so when you're talking about that level of translation, what you're really doing is you are removing all of the language, you are communicating with visuals only, diagrams, arrows and numbers, and making everything as clean and simple to understand as possible. And this is completely standard in manufacturing. Anyone who's ever been in manufacturing, whether it's products or fashion or anything like that, it's completely standard to only use images, arrows, and numbers. And everything was going fantastic. I was in that job for quite a while, and then my husband had a rather nasty work accident, and he had to go through multiple rounds of surgery and rehabilitation and lots of really awful stuff. And I had never before been exposed to the sorts of health communication standards that we currently use for our patients, and I was absolutely shocked. I was horrified. My husband was laying in a hospital bed, having just woken up from surgery, major invasive surgery, and they came in and they handed him a fistful of written paperwork and said, "Here you go, here's all the instructions, follow it to the letter or else you'll get really unwell. Okay, bye." And it was just horrific. And, as happens to many patients in the healthcare system, he did end up having complications that came from his own inability to understand the health instructions in the format that were given to him. And I couldn't believe that this was how we are communicating the most important aspect of our lives, right? Health is universal. Everybody at some stage is going to have to deal with it in one shape or another. Yourself, your family, we all end up in the healthcare system at some point or another. And we are just kind of expected to try and figure it out with the tools we're given. And it's not enough. So I did what every person who thinks they've got the clever solution to a very complex issue does. And I put a group of people together and decided that visual communication was the answer, thought of a clever business name, went around and started trying to work as a graphic arts studio and try and create these beautiful bespoke images for teaching health concepts in healthcare, and very quickly realized that nobody is happy with the current standard, but the reason it's there is because there has not been enough of a focus in the healthcare system on visual communication. There's no funding for it, there's no budget for it, and the requirements of our fantastic community here in Australia are so diverse that there is just not one single answer. So we realized that what we needed to do was far more broad, and instead we changed the way we work to offering a solution so that healthcare professionals can create education content tailored to their patients' needs. So if you speak a language other than English, if you have lower literacy levels, if you have cognitive issues, we instead created a tool that would allow accommodation for all of those things. And it's been a really amazing journey. We started out kicking and screaming, and it was unfortunate timing. When we first released, it was just off the back of lockdowns because of COVID, and the healthcare system and the public obviously were just in a panic. The response that I got quite a lot was, we've got more important things to worry about. And that, to me, is really unacceptable, but I completely understand. It was a horrible situation that we all universally went through. But we're in a really wonderful situation now where, because for the most part we're through the worst of it, and we can start focusing on other areas in health that need to be addressed. And for me, I am day and night championing the idea that we have let patients down in the way we communicate with them. We have such a incredibly, wonderfully diverse population. Everybody has unique needs, unique learning styles, unique languages, and we are essentially communicating with all of them exactly the same way, which is really high literacy written content. That's how it used to be. That's not what's happening anymore. We've had some wonderful traction within public health. State health services now are starting to roll out our services. The way we create and cater to our health population is changing, and healthcare is now, thankfully, at the stage where they are realizing that this is a very real issue that needs to be addressed. And I am so incredibly proud and honored to be a part of that movement, especially because this stems out of something that was really the worst situation that my husband had ever been through, and the worst situation that I had ever been through. And we really did experience it. We really did get let down by the health system in the way that we were educated about everything that would be required with his health journey. So it's really wonderful to have been able to take something that was so devastating and eye-opening and turn it around into something that is going to be able to help patients Australia-wide and very soon worldwide. It's absolutely incredible that we've been able to find a way to support such a wonderful, diverse community in something that is so incredibly personal to everybody, which is your own health journey. So it's been a really wild couple of years, but I really am so incredibly glad and honoured to have been able to be a part of this movement.
Wow, Chris, it's you have been on a roller coaster ride. It's just amazing how sometimes out of adversity, something good actually happens. So, in your experience, what has been the biggest challenges in making health education accessible and equitable for diverse patient populations? And how has your organization aimed to overcome these challenges?
In the early days, the largest challenge we faced was just the fact that no one in health was willing to put any resources towards fixing this issue. So it was really disheartening to meet with people who worked in the system and ask them about their experiences educating their patients, and they would all come back to us and say the same thing. Most patients don't understand, most patients will make mistakes, they won't do it correctly, they'll get worse when they shouldn't be getting worse, or they won't. It was very much us versus them. Our patients don't listen to us.
Right.
And there's so many studies now that show that that was because of just poor communication and poor education. Nobody wants to get sicker, right? That's just silly. So in the early days, that was the biggest challenge, was just trying to get people to not admit that it was a problem. They agreed that it was a problem, but trying to get them to agree that it should not be a problem and we should be trying to address it. Now we're past that. Thankfully, we are past that stage. I rarely go into meetings and have them push back in that way anymore. Now the biggest challenge is trying to understand how we can help represent the communities that need this education content in an inclusive and collaborative way. So we have this this view that we don't design on behalf of, we design with.
Yes.
A friend of mine said something really poignant this morning, which was fantastic, and it was nothing about me without me. And we do really try to keep to that ethos. If we're going to be working on content designed for First Nations Australians, we will find First Nations artists to collaborate with. If we're working with immigrant communities, we'll be working with representatives within those communities. At this stage, for example, all of our content has been designed for low cognition and colorblind patients. So everything can be understood by someone who may be aging in the healthcare system. They may have different mental health issues, or they could be something as simple as colorblindness, which is incredibly common in our population. We will actually pass the content through people from those subsets of patients and actually say, is this okay? Can you understand it? Is there anything you'd like to change about it? And we really try to make sure that we are covering our bases to make sure that the people that we are trying to help and trying to educate have had input in creating the resources.
That's absolutely incredible. So you really ensure that the visual aids that you create through your company cater for that wide range of cultural, linguistic, and educational backgrounds, correct?
Yes, absolutely. It's you as so myself as a academic. I have I work as a lecturer. I work as an anatomist and medical researcher. I can't understand how someone who has never been exposed to medical content before, doesn't speak English as a first language, and then maybe is also colorblind, I can't understand how, or I can't guarantee that they will be able to understand it the way I'm trying to communicate it. The only way to make sure that's happening is to check, to ask.
Yeah. It's such a simple concept, but it can be missed, especially in the health profession. So, can you share how feedback from diverse user groups has shaped the evolution of your company? And perhaps give examples of a change that you made based on the feedback.
Yeah, one of the earliest things that happened was I do not necessarily have any cognition issues. I don't have any vision problems. And I have a very long history as a designer. So I'm kind of the worst person to be designing for someone who might have some of these special needs.
Yes.
in the early days when we first designed the layout of the software and some of the early assets just to do like a proof of concept, we had someone who was colorblind have a look at everything, and not the assets that we had created to be housed in our software were okay, but the software itself was actually quite inaccessible to someone who had color blindness, because the value difference in the colors and the way we had designed it to look pretty was actually quite inaccessible to someone who has color blindness. So we had to go in and actually make changes to our own internal software, not even the output, but the software itself. And so that was a change that happened early on. And I feel like we're continuously evolving the way we work based on feedback. So we are now at the stage where we are building in a low literacy translator tool, because a lot of patients have, the majority of Australians have a lower than average literacy rating. They are sitting at about the age 10 to 14 range for their reading level. And it's almost impossible to ask clinicians who have 12 plus years of university to write to that level. It's just, they are hardwired into academic tertiary level education. So we're building in a tool that will actually do that for them. And it's things like this, little changes and tweaks. We've been asked recently to consider how our content might be applicable to blind and low vision patients, because obviously being visual first tool, it doesn't actually help any patients with blind and low vision. So, we're thinking about how to problem solve that issue next. And every step of the way, you have to think about the intersections of the community as well, because you might have someone who is a First Nations person who is blind and low vision and then maybe has a lower literacy level. So you have to think about how all of those intersections come together and how you can work to try and give the best possible outcome.
Wow. It is quite complex. So you've led teams on large-scale tenders for governments around the world. How has working in such diverse settings influenced your approach to creating inclusive health education tools?
I think the unique perspective I brought to this right at the very get-go was the idea that there are very incredibly large consequences that happen when people don't understand what you're trying to communicate. So when you're leading a team of manufacturers for a $50 million tender, you send the tender over, the specification package over, and what you get back is incorrect. It's unacceptable. You can completely railroad a company by doing that. So it is completely imperative that they understand how you're going to be communicating with them. And there is really that focus in that industry that at all costs, no matter what, the manufacturer has to understand what you need back. It must be done correctly, because there's very real consequences. So when I started in health, I couldn't understand why we aren't thinking the same. Like if a patient doesn't understand, you're not going to lose $50 million on a manufacturing contract, but that patient might lose their life. And that's so much worse. The rates of medication mistake and potentially preventable hospitalizations around the world, but even in Australia, even in a country where we have one of the best healthcare systems available, our rates are still shockingly high. It's about 20% of our healthcare budget. So it's not something that is acceptable. And I can bring that lens to it because in my previous role, failure was not an option. It was, we have to find a way to communicate this, and it has to be done correctly no matter what. So I sort of try as much as possible to bring that same lens to healthcare education for patients.
Wow, that's just incredible. So let's talk a little bit about measuring impact. How do you measure the impact of your company on improving patient education amongst diverse populations? And what have been some of the key findings with the results?
So I should preface all of this with saying we're very new. We only released our MVP last year. So we are still very new in the healthcare system. But one of the things that we are currently measuring, I don't have the results yet, but we are currently measuring is the amount of time it takes a pharmacist, for example, to explain a complicated medication to a patient. So originally, and I'm sure you will have seen it, I'm sure everybody's seen it. You open up a box of even something like paracetamol, and then you pull out that little paper slip that's about 12 miles long, and the writing is so small that you have to get out your magnifying glass, and it's just horrible, and you just can't, like most people just don't read them, right?
Yeah.
When you're talking about a medication that is incredibly dangerous or is used in an at-risk population, it's imperative that they understand. So more often than not, the pharmacists end up spending a fair amount of time really coaching the patient and really trying to get them to understand how to use this medicine.
Mm-hmm.
So one of the things that we're measuring is how much faster that can be achieved if you make the format that you're presenting this patient with that information, if you make that format more accessible. So in this instance, we're using very basic diagrams, very, very small amounts of low literacy language, and sometimes very small, very clean and simple animations. So that's the first thing we're measuring is like pharmacist time to a good education outcome. But what I would really, truly love to measure, and something that we're setting up with some of our early customers, is measuring the outcomes post-procedure. So things like infection rates, medication mistakes, anything like that, using the old method of educating, which is give them a printout that they don't read or that they lose, versus the new version of educating, whereas we're using visual aids, accessible language, and making it something that people will actually resonate with. So that's one that I'm very excited about.
Oh, that's just wonderful. There's so much work to be done in this field. You actually forget. So from your perspective, what is the future of health education in terms of incorporating diversity and technology? And how is your software positioned within that future?
I truly believe that the future of health education is diversity. There is no one format of education that every single person on this planet resonates with. Some people like podcasts, some people like animation, some people like reading the written content. Some people would rather sit and have someone explain it to them face to face. And I think more and more the future of health education, the way we are going to improve patient outcomes within the health system, is by recognizing that and starting to cater to it as much as is possible. So we already have our diagrams and animations, which can be created incredibly quickly in the healthcare system. We're going into a universal translating tool, a low literacy tool, which will allow for healthcare professionals to actually provide some of that written content just in a lower literacy format. We're about to begin work on our blind low vision support tool, which is something that I'm incredibly excited about, but it is going to be quite a challenge to overcome. And we actually just this morning have been in contact with some really fierce patient advocates in Australia about developing a video series of patient lived experiences. So actually having patients who have been diagnosed with a certain health condition or had accidents happen, or any of these sorts of health conditions that people day to day live with, having them tell their story, how it affected them, what their treatment was like, what their lives are like day to day. Because no matter what, the best learning outcomes will always come from providing a diverse range of the same information, just presented in different methods.
I love that. Wow. Yeah, those testimonials will definitely go a long way. So what advice would you give someone looking to make a difference in health education, especially in terms of incorporating diversity and accessibility?
I think the first step is recognizing that the current method isn't working, and realizing that anything extra will help. Anything on top of what we're currently doing is going to make things better. First and foremost, talk to the community, talk to the communities that you are trying to help. You can't guess, and you can't work on behalf of. You have to work with. You need real feedback. You need lived experience. And then just start small. It's such a, you hit the nail on the head before. It is such an overwhelmingly large problem. Health is just a huge subject. No one doctor knows everything, so there is so much out there that needs to be addressed. But rather than looking at the problem and saying it's too big, I can't fix it, look at the problem and go, okay, what can I fix? What can I contribute to this? So if you are a pediatric oncologist in North Queensland, looking at the entire problem of health literacy, it's like, I can't possibly solve all of this, but maybe you can create some more accessible content for your patients' parents so that they can look after their children a little bit easier. If everybody just sort of takes just a little bit and just tries to address a little bit, then we will eventually get there. But again, the most important thing is it's got to go back to the patients. You can't work on behalf of a community. You have to work with a community.
Yeah, there was an interesting TED talk I watched once that said, if you want to help someone, shut up and listen. So a lot of times we come up with solutions without consultation with the communities that we serve. And that's where a lot of these issues end up becoming a problem.
I completely agree. And I think people are always, I'm a bit of an optimist about people who work in the healthcare system. I really do think they are genuinely trying to make patients' lives better. People who come up with solutions and then don't talk to the community, I tend to think a little bit of that is just being self-conscious that your idea is going to get shut down, or that you're going to get negative feedback, that it's not going to be well received. But the honest truth is that if that's the case, you're in the perfect situation to say, okay, what would work? What would you like? How can I help you? And no matter what you develop, just asking those simple questions is going to far outperform anything you would have thought of on your own. And the only difference is maybe you don't get to claim being the cleverest person in the world for having solved an issue that nobody else could address. Collaboration can lead to much better results than anything you could do on your own.
I love that. Yeah, collaboration is everything. So my last question for you is, how can listeners, regardless of their educational background, contribute to the conversation and efforts around diverse and accessible health education?
That's a really, really interesting question, because this is a relatively new, I would never discount the amount of work that some really, really amazing health literacy advocates have been doing for decades in the healthcare system. But for a very long time, they've been fighting alone. It's only just now coming to the stage where there's a lot of us starting to come together and say, hey, this is not acceptable. We need to fix it. Yes. Because this is a relatively new movement that is just now starting to gather a lot of momentum, there isn't really that many outlets for patients to contribute their voices and have their voices be heard. Probably the best thing is there are health consumer forums around Australia, and they are incredible for anyone who has any experience as a patient or a carer in healthcare. You can join up with a health consumer forum. You can give your experience and your advice. And honestly, even if it's only to sign up to them and say, look, I had this really awful experience. I hated it because of this. I felt scared. I felt lonely. I felt lost. I felt forgotten. A lot of people are really hesitant to give that sort of feedback because they think it's not constructive, but it absolutely is. Everyone's experience and everyone's voice coming together and showing us exactly where the pain points are is so important, because you have people like myself who, apart from the strictest definition, I'm not a healthcare consumer. I am working on behalf of a corporation. Really, a lot of times my voice can fall on deaf ears because contributing their voices and their stories, and they can stand up alongside people like myself, people from not-for-profits, people from consumer forums, and say, no, this is not okay. It is so powerful.
That's just amazing. Chris, thank you so much for turning a situation that could have impacted your family in a worst way into something positive that's helping everybody now with this amazing software. It's just an absolute pleasure to connect with you and to see what a difference we can all make with all of the daily challenges that come at us. Thank you for being here tonight.
You're more than welcome, Gertrude. Thank you for having me.
And thank you to everybody who's tuned in today. The Diversity Connector is a platform that brings you stories and voices of people from all over the world, making sure that we celebrate our diversity, we recognize diversity, and we use it as a strength and not a weakness. So tune in again tomorrow when I interview yet another amazing guest. In the meantime, have a fantastic day, morning, or evening, wherever you are in the world, and bye for now. Thanks again, Chris. And that's a wrap, everybody, on today's episode of the Diversity Connector podcast. Thank you for tuning in and being part of our vibrant and global conversation. I'm your host, Gertrude Mache, and it's been an honor to share this space with you, where voices from all walks of life come together to weave a tapestry of diverse perspectives. Remember, every story you've heard today is a thread in the larger fabric of our shared humanity. So, as you step back into your world, carry these stories with you and let them inspire you to embrace and celebrate the rich diversity around us. Don't forget to subscribe, rate, and review our podcast to help us share these inspiring stories with more listeners. Do follow us on social media by looking for the Diversity Connector podcast for more updates. Until then, keep connecting, keep listening, and keep celebrating the beauty of diversity. This is the Diversity Connector podcast signing off. Stay curious, stay open,